The issue of needing a permanent colostomy is possibly the most feared downside of being diagnosed with rectal cancer. We can decide whether or not it's possible to connect things back together again by determining how close the tumor is to the sphincter muscle. There are many ways of doing this, for example, CAT scans, MRIs, colonoscopy, flexible sigmoidoscopy, but to the colorectal surgeon, the most important part or important way of determining this is physical exam with a digital exam of the rectum. In that way, I can find out by physical exam how close the lower edge of the tumor is to the top of the sphincter muscle. If I have about a centimeter, which is less than half an inch, I know that I can connect that colon back up again, and that patient is not going to need a permanent colostomy. It's very important to know about this issue because across the country with national data, the average permanent colostomy rate for a patient diagnosed with rectal cancer is 30%. We have a very skewed population here in that many of the patients we see have very difficult, very low rectal cancers, and they come here for a second opinion because they've already been told that they need a permanent colostomy. And the vast majority of the time, we're able to save the sphincter and give them continuity of their intestine again. Now, they may need a temporary bag while that surgery is healing, and that's usually an ileostomy or a bag made from the small bowel. But in doing so, they avoid a permanent colostomy. And just for comparison, as I mentioned, across the country, the permanent colostomy rate is about 30%. Here at Mayo Clinic, our colostomy rate is less than 5% because we have been trained in these special sphincter sparing operations.